Welcome everybody. This is going to be a very interesting session because we're not going to tell you stories. We're going really into the details of challenging cases and how to solve the challenges. So I'm very happy to be here together with Sonia Petronio, chairing the session. The objective of the session is to gather information about how to tackle the most challenging situations in TAVR. And without losing much time with introduction, because it's always very boring, I would like to start already with the first presentation from Professor Gerkens, who will start already in a difficult environment, which is bicuspid valves, an area where I think Evolut R is a really good device.
Dear Sonia, dear Francesco, thank you very much for the kind invitation. Dear colleagues, and I try to step in the bicuspid valve anatomies, and I try to make some points beforehand, discussing what we are facing, and then I will make a point of discussion with a case presentation, and that is very open for discussion and looking forward. So we do all know that there are different morphologies in bicuspid valves. Type O, type 1 is the most common, but more recently there was a very nice paper published last year dealing with leaflet morphology to identify differences in bicuspid morphology and also the leaflet orientation as seen here. And especially they addressed the importance of the RAFE and the calcification in order to forecast what device may be used and how the device will behave. That is the situation we are facing sometimes, and you see here a CT post-implant of a device, and you see the supraannular level, it's circular. What is the beauty of this device? But you still, how constrained the device may be if you are dealing with very severe bicuspid anatomies, and that is basically demonstrates very nicely the difficulties we have to overcome. So the challenges is that these valves are often heavily calcified, and that means that we have an incomplete valve expansion due to the calcified RAFE, and that is consistent with paravalvular leak, maybe consistent with annular rupture that we are fearing, and it's most often associated with a large ascending aorta and a very oval annulus. So sizing, and just by the way, this picture is 10 minutes walk from here in the Foundation Louis Vuitton, but that is something else. Because I try to explain, if you do annular sizing, it's maybe the neck, but how far we can open the mouth if we do the cry. So what to, in terms of sizing? Do we still consider the basal ring, the annulus, that is adequate for sizing, or do we need something else which is called the effective orifice area or the intercommissural distance to get the best idea how far the device should be expanded and can be expanded, also the best oversizing? And you see all days, you know, this picture is dealing with the annulus, and you see the perimeter-derived annulus. But in the bicuspid anatomy, in the supraannular measurement, you see some elliptical drawings, and some people say it may be a little bit artistic, so at least it's not very easy to duplicate these times. So we should consider the annulus of the leaflet anatomy, calcium RAFE, in order to consider the best treatments, because we have to balance the risk of undersizing and the risk of oversizing and the given consequences doing so. So that is an example, and it's a very typical example with a calcified RAFE, and a diameter from the annulus plane is 25, but you identify very clearly it's a bicuspid valve, and that comes back to echo, and echo tells you also in TEE if a commissure has flow across or if a commissure is closed. And if you see these pictures, it's very clear that it will not expand easily to a circle. Just a comment, sometimes you see the highest gradient from the suprasternal approach, not coming from the apical approach. Don't miss this approach. So that is the angulation, and you see it's a distal horizontal aorta. That is a stiff wire used to deploy this valve, and you see it's a huge root, and you think a large valve may be needed. But I want to make the point how to size, and because we have no validated CT sizing methodology, so I still think the balloon sizing is of importance. And here we are using a 22 millimeter balloon, and you do while we are injecting, the balloon is sealing despite it is not touching fully the outer range. That means that we have any idea, and you look very carefully, you do see some indentation at the balloon that gives you another idea where the anchoring zone is. Where is the level of anchoring? Because we are not dealing with the annulus at the depths, we are looking for the leaflets anchoring. And here is the balloon simultaneously with TEE and angio, and you can identify the same. So basically you see if the balloon is sealing and where is the anchoring zone, and that is where you are basically targeting. Because the 22 millimeter balloon was sealing, so the effective orifice area is much smaller than the annulus measurements. We are using a 26 millimeter device, and you see how the device is going to open up, and that is only one projection. You know we should use two projection, and that is what you end up during the procedure. You still have an elliptical valve at the inflow, and you do see some regurg. So in this kind of patients, you do need, and maybe 40% of the patients, a balloon post in order to expand the valve according to the given size. And the lesson is, don't upsize the balloon at this step. Use the same balloon which is proven to seal the annulus. And you see here the echo while we are doing the post ballooning, and you see how nicely the inflow expands. At the end of the ballooning, you see some recoil, but that is good enough to adapt to the anatomy of this given anatomy. And that is the final result with basically no regurg. And if you do echo, you can identify the difference between pre and post balloon dilatation. So I really think that balloon techniques, it's not ballooning in terms of pre-dilatation, it's ballooning in terms of sizing and opening. So I would like to conclude, and these are also questions involved, that bicuspid aortic valves requires a frame implantation according to the leaflet levels, which is different from the annulus. And there the balloon gives you, in terms, if you're looking for the indentation, some idea where the anchoring zone is. And I think really in this situation, the possibility to resheath and reposition is crucial, because it's not always able to have the first time. And of course, if you do post-ballooning, use the same balloon which was identified. So I tried to make some discussion points. First of all, and that is not simple and it's not easy, identify if you are dealing with a bicuspid morphology. Second, I want to discuss the concept of balloon sizing and post-ballooning. And I think it's not related to the word downsizing. I think we should go for best or correct sizing in bicuspid, and we need more detailed information how to identify best. And up to now, the balloon may be of help. Thank you for your attention.
So, thank you. I would like to inform you that whoever wants to ask questions is very welcome, first. Second, has to go on the mics, because again, we are recorded. So I would be I like to start the discussion with you. First of all, tell you thank you, because you know all this information really is creating some science beyond what are our impressions. And I really believe, I've been always thinking that bicuspid, we have a wrong sizing methodology, and that sealing happens somewhere else than in the annulus here. It is more conical anatomy. So my first question to you is exactly, you already put it in your last slide, so our job is very easy. I think sizing is probably, we understood more or less that it's not really ideal. But also, given this anatomy, also the implant depth is probably something that we have to revise for this particular anatomy. So what is your target when you implant the bicuspid valve?
Thank you for this question to clarify. And that is a second point I would draw from the balloon technique to find where is the indentation of the balloon, and then you realize how far you can go. And then it creates a new line where you relate it to your implant depth. So basically, when we are saying we are shooting for a high implant, we are shooting for a very high implant due to the annulus, which is not where we're going to anchor. So I think we should stay with the same target depth, 3 to 5, but in relation to the anchoring zone and how to identify the anchoring zone. That's why the balloon, in my eyes, is still helpful.
So let me clarify for the audience. Did you understand what he's saying? I mean, you implant this valve 5 millimeters maybe above the annular plane, which I think could make sense. Now my next question is, thank you, how often have you done already like this? Because I believe that you were implanting like everybody according to the pigtail. Now you have been changing this. So how long ago did you change your practice?
I think that is, according to the pigtail, that is due to the annulus, because the pigtail gives you the insertion of the non. But here in the bicuspid, and that's why I think the repositionable and TEE is extremely helpful to see that you have enough anchoring in terms of the leaflets, regardless where the pigtail in the final step is. We have to stay below the anchoring zone, and that is a way to find the anchoring zone different from the CT sizing and different from the pigtail guidance.
One question I wanted to ask you is, do you think that we are facing more, a different number, I mean more bicuspid than we would have thought some years ago with looking at CT more carefully?
I'm quite sure that we are missing a lot of bicuspid anatomy when we are starting the procedure. That's why I always encourage to have a TEE to look if you are suspicious. And sometimes if you just see the echo and you see very eccentric opening in this type and the very calcified leaflets, always cross-check if it's not a bicuspid, and that can be done during the procedure with TEE guidance. Second, if you only see the standstill pictures of the Tremengio report, if you don't go for the whole level playing with your CT, you will miss, of course, a lot of patients, and that may be the key, to identify the intercommissural distance, to identify the raphe and the length of the raphe in combination with the calcification.
Very good point. Just to reinforce it, there are two questions. You know, if you do TAVI, don't let the radiologist tell you what you have to do. You have to watch yourself, your CT scan. So, Dr. Milot.
Just to reinforce what Ulrich has said about the importance of the CT, you get a lot of information from the CT, particularly in a bicuspid. You can tell how high the calcium is on the CT scan, and it usually lies between 4 and 8 millimeters above the level of the annulus. So I would just like to reinforce that point. I have a question for you, Oli, about the balloon. When you do the balloon sizing to try and get a feel for what size device you should take to look at the ceiling, to look at the indent in the balloon, can you tell me what you're looking for exactly? Because I know of a case that was done recently whereby the operator took a 10 millimeter balloon and put a 10 millimeter balloon in the annulus and had perfect sealing. So it's not just the sealing we're looking for when we do a balloon predilatation, right?
Exactly. Thank you for this question to clarify. If you take a very large balloon, you will seal always. You have no additional information with ballooning. If you take a small balloon, you can have some sealing and you have no indentation and you have also no idea what you are doing. First, what I do, I look for a semi-compliant balloon to shape to the anatomy while opening the balloon. I go with increasing atmospheres to try to modulate a little bit the annulus to see how the balloon reacts. And then I go for a smaller size, always smaller size in relation to the annulus. And then a balloon which maybe gives you the answer between the two sizes. And I'm looking also, and that's why I think TEE in the bicuspid is still needed, to see how the valve behaves, how the calcium will open up. And then I choose a balloon which gives you just the in between the two sizes, so a 20 millimeter balloon or a 22 millimeter balloon, 26, 29.
Could I only comment 1 second? I think that the technique of balloon, which is extremely useful, it could be sort of an intermediate step. We will probably need a way to measure, because, I mean, the person that is very expert knows exactly what kind of balloon to choose. But the person that is not aware, it can choose a smaller or a too bigger balloon. So I think we need a further step to do that.
I have mainly
There was
There was a
another
question
question.
behind, please, first. There is time for
My
everybody.
question was the same. That how can we choose the size of the balloon? And my another question is, for the measurement of the annulus, which parts of the balloon are you measuring? I mean the appearance of the indentation, or which part? As we know that there are some other balloons in which there are some indentation in the waist segment, like intervalve or nucleus balloons. What is your recommendation for this?
Okay, to be very clear, a semi-compliant balloon to see that it adapts to anatomy. Second, the balloon which is straight. Don't use a dog bone balloon to start with, because then you lose your information in terms of to identify the anatomy, and use increasing inflation pressures. And what you can do in order to have a better view, do a rotational angio while you balloon, because you may miss in one orientation, in one plane, the indentation. So it's helpful to do a rotational cine while the balloon is up.
There was a question here.
Yes, I have mainly a comment to your remark regarding the bicuspid anatomies we are missing. Just an experience from our center, when we were asked to participate in the multi-center registry by Raj Makkar, we thought we only have a few cases, like maybe 3, 4, 5 cases. And then when he sent us his fellow and he analyzed all our CTs, there were much more than we thought, much more than we thought. So I think if we have a closer look at the CT, we will definitely not miss these anatomies. And maybe one question to you, Dr. Gerkens, regarding the anchoring. How do you check for anchoring, especially if you are aiming at a very high implantation? How are you sure that you anchor? Do you just look at the sealing of the valve before releasing it, or are there any tips and tricks to make sure you're anchored even if you're in a very high position?
Very high position, again, means high position in relation to the annulus. We're still looking to have the valve frame below the anchoring zone, which is identified by the leaflets level, the Mount Fuji type, of the bicuspid. That's why TEE comes back, to be very sure that you are touching all the leaflets and you are below the anchoring leaflets area. That's why I still think that for these procedures, TEE is helpful, just to identify that we are at the right depth.
Okay. Okay, thank you. So now we will hear something about treating complex large annulus from Darren Milot. Milot? What is the correct pronunciation?
It changes depending on which country I'm in.
Oh.
You could all hear me.
US is Milot, right?
In France, it's Milot. In Ireland, it's Milot. Or my primary school teacher, when I was a kid, used to call me Milot.
Miles.
So
we
dealer's choice.
will
as
name you
will.
Darren. It's okay?
It's
I
a
love
little
that.
easier.
That's the
So, dear chairpersons, thank you for the invite to speak on treating complex and large annuli. And when I thought about this a little bit, complex large annuli, what I realized was that maybe we could turn these two letters around a little bit, because until recently, for me certainly, as an Evolut R user, that pretty much all large annuli were complex for me, and that has changed recently in my practice. Most of us remember these kind of pictures where we had a 31 Evolut R in our hands. This was a 31 CoreValve Classic in our hands, and this was a difficult valve to control. And certainly, when assessing the CT scan, I would always try and make the valve 29 if I could, because this was a difficult procedure. This is a case whereby the valve was initially too deep. We pulled it back, and of course it ended up supraannular, and a similar case whereby the valve is too low and you're left with very severe paravalvular leak. But nevertheless, we did have a significant proportion of patients who needed larger technology. This is a study many years ago comparing transesophageal echo sizing in a German population, comparing transesophageal echo sizing to CT perimeter. And what you'll see here is that even with the 31 millimeter core valve, that about 9% of patients were still beyond the sizing limits of that valve. And if you add that to the 21% of patients who were 31 valve, you had about a third of your patient population who has a large annuli. So this is a significant proportion of patients. And for me, with previous technologies, these were difficult procedures. Of course, we've had three Evolut R sizes available until recently, but the release of the big daddy, so to speak, the 34 millimeter Evolut R, really has made treating large, complex annuli much simpler, certainly in my practice. To give you a brief overview of the system, it's largely the same as the other Evolut R devices. It treats annuli from 26 to 30 millimeters. It's gone from a 14 French inline sheath to a 16 French inline sheath, but certainly in my practice that increase in diameter hasn't changed the number of patients that can receive TAVI or receive this system, because those larger patients tend to have larger peripheral vasculature as well. What was most impressive for me is this. This is the acute hemodynamic results of the initial US trial. And looking at that effective orifice area of 2.8, we have never seen a device, surgical or transcatheter, that can give us an effective orifice area of this. This is double what is achieved in the partner trial by surgery. So not only I believe that this makes my life easier, but perhaps it gives my patients a better outcome. So I'm going to share two cases with you quickly if I can. The first case is a case from a couple of weeks ago, a very high-risk individual. So an 87-year-old male, he's class 4 heart failure, and he remains in hospital until he can get his TAVI. He has an extensive medical history. Most importantly of these, he has congestive cardiac failure, and he also has fairly severe chronic kidney disease. However, before this, he was actually living independently, remarkably. He does his cleaning, his shopping, and of course he's Irish, so he gets down to the pub for a glass of Guinness most evenings. But he's tiny. He's 44 kilograms in weight. His GFR, as I mentioned, was an issue. His GFR is 30. His BNP is 12,000, demonstrating how sick, how poorly this man was, with an STS score of 17. So a very sick patient. His echocardiogram suggests severe aortic stenosis, but with his ventricle, it's difficult to tell. He has a mean gradient of 31 millimeters of mercury across the valve. He had a dobutamine stress echo where his valve area remained low, and his mean gradient came up to 45. So a sick man with poor left ventricular function. His multi-slice CT scan demonstrates the following: an annulus of 83 millimeters, so just above that 29 millimeter Evolut R, but with very large sinuses. And what made this, I think, a challenging case is the lack of calcium on the aortic root. There is a little bit of calcium at the base of those leaflets, but really this is a very uncalcified anatomy. And this certainly makes me nervous in terms of ensuring anchoring and sealing in these cases. To I suppose, more scientifically assess the amount of calcium, you can assess the volume of calcium, and this gentleman has 309 millimeters cubed of calcium. Your normal aortic stenosis patient would have at least 3 times this amount of calcification. So our plan for this sick gentleman was a transfemoral TAVI, a direct implant of a 34 millimeter Evolut R, and we used the double S curve for implanting in most cases. In fact, this gentleman also had a significant curvature on his spine, and I'm glad that we used the double S in this particular case, because if you look at this implant view suggesting an LAO 63 cranial 1, I think that we probably would have spent a lot of contrast in this patient trying to find the right implant view had we not used this. In terms of preparation for the case, the best thing that I can say about this device is that it responds in exactly the same way as the other Evolut R family. You line up the case, you assess your implant depth, you release the valve slowly. It takes a little bit longer to deploy this valve because of the larger size, but it really responds in exactly the same way as a 29 and a 26 millimeter valve. Unlike the CoreValve Classic, which at this point of your procedure is heading towards the ventricle, this valve deployment is very stable and really requires very little in the way of manipulation. Again, the release phase of the valve is very slow, very controlled, And in this particular case, we did not do a final aortic root shot because of contrast load. But when you see this type of result, perhaps with 2 tiny jets of paravalvular regurgitation, I think in this patient this is an exceptional result. A second case that I might share with you is pretty much the exact opposite of the first case. I'm not going to go through the clinical scenario, but this is a case with an annulus of 97 millimeters, so a very large annulus in this patient. And unlike our first patient, this is an extremely heavily calcified aortic valve. This patient had 2010 millimeters cubed of calcium at the level of the valve. The initial deployment, again, very slowly, using double S-curve for that implant view, results unfortunately in a suboptimal position. The valve was a little bit lower, so we simply recaptured the valve in exactly the same way as you do for your 26 and 29. We paced at 110 beats a minute, which I think I suppose reduced the little bit of movement from of the valve during deployment that was due to concomitant aortic regurgitation. I think this valve should be implanted high. I would suggest between 3 and 5 millimeters. And again, a very slow deployment of this valve gives you great accuracy. And again, in this case, a very acceptable final result with a single puff of aortic incompetence that will probably go away within the next number of weeks. So to conclude, I think the 34 Evolut R facilitates TAVI in patients with extremely large annuli. It's suitable for those large anatomies with minimal or severe calcification. I think the kindest thing that I can say about this device is that it deploys in exactly the same way as the other Evolut R devices and is vastly superior to the CoreValve Classic. And I think that it extends the important benefits of recapturability, repositionability, and removability to all patients at this stage. So thank you for your attention.
So Darren, thank you.
Pleasure.
Well, I have to say that he said a really true thing. When he said that, he was trying to use a 29 instead of a 31, I remember that for the last couple of years, I was sort of saying, I want a 29, I don't want a 31, because it's true. Now things changed completely with this new kind of shape of the valve.
Absolutely. Yeah. And many of us would have, if we had a 31 case, we would opt to use a different technology because it was difficult to control.
Yeah, I have to
the
say
opposite is now true.
I've been honestly disregarding 31 in my practice. It was too unstable to be working well. And this technology, I think, is really going in the right direction. Let's go one step back, 1 second. So I don't remember anymore the percentage of patients who have a large annulus in that statistics.
About a third of patients require a valve size that's greater than 29.
Right. And would it be different if we exclude bicuspid valves?
So this only included tricuspid patients. As Oli has shown very nicely, although the annulus is more elliptical, although you have larger aortic roots, in bicuspid you very often need a smaller valve. So perhaps as we treat more bicuspids, we need a smaller technology rather than a greater number of patients with large anatomy.
Okay. That's good. So one consideration, overall consideration, this is a session on challenges. So do you think that we can declare now that the larger anatomy is not anymore difficult?
So the 34 valve, we've had it since January of this year, and these are the most challenging cases that I could come up with. One that had calcium and one that had no calcium, because I find that the deployment of this device is really very simple. Now, I suppose the one caveat to that, and I think Mohammed is going to speak about that in a few moments, are those vertical annuli. They are still a tough challenge. But for me, treating large annuli, I no longer get nervous going to the cath lab with a 34 Evolut R in the same way as I did with a 31. So is the challenge over? I don't think we get complacent. But of course, I think this technology makes it a lot easier.
Yeah, so I think a general statement for TAVI, in my opinion, that the larger the anatomy, the more challenging is the procedure. Number one, this is obviously something that it goes across the board, that any technology you use The larger the size, the more challenge. This is clear. Obviously, we are now having devices which are designed for this challenge, and probably we don't have to be more too much worried about approaching these cases. But on the other hand, you need to be very careful, also because usually when you have a larger size, you also have some degree of horizontal aorta. I mean, this is they go to almost together, these two conditions.
There is a question.
Yes, a question maybe regarding the second case you showed. I mean, you stretched the border a little bit regarding the perimeter size recommended for the 34 millimeter valve. But on the other hand, this was a heavily calcified valve. Is this a common practice in your experience? Is it possible to do this when you have a lot of calcification?
Yeah, so I think it's important. So Mohammed is referring to the fact that the perimeter in the second patient that had very severe calcification was 97 millimeters. The upper limit, according to the IFU, for the 34 millimeter Evolut R is 94 millimeters. And this is the first patient that I have encountered with such a large anatomy. I don't think that this is routine. I don't think it should be routine. But in this particular patient scenario, he was a no-option patient. This is a young man who had no other choices. He had very severe lung disease, had been declined by 2 separate surgeons. And with the ability to recapture device, we felt that the risk involved was relatively low. So if we had a good implant height, deploy to 80%, it then gave us the option, if it was imperfect, to remove the device. Should it be encouraged? No. But again, I think when, as Ulrich has shown us, in heavily calcified anatomies, I think there are certain situations where you can downsize the device. And I don't think that just applies to bicuspid. I think that also applies to heavily calcified tricuspid devices. We thought very long and hard about this particular case. So is it routine? No. Can it be achieved in specific cases with careful consideration? I think yes.
Do you think that sometimes when you have heavily calcified valves, it may help you the fact that you don't pre-dilate the valve and that the cusps just help you to seal the valve?
Yeah, I think, again, this is an important question. It depends on your oversizing, Sonia, I think. If you have a very comfortable level of oversizing, I think you have a decision to make. In my practice, for very heavily calcified valves, I pre-dilate because I want to aim at a high implant, and I don't want to do a post-dilatation under rapid pacing if my implant is at 1, 2, 3 millimeters. And so I would rather do a pre-dilatation implant and not require the post-dilatation.
But in this, where you are borderline, you're over the IFU limits, probably this could give you one chance more.
I think so. I think so.
Again, for the audience, let's take advantage of this discussion. How often do you predilate overall?
Probably if you take bicuspids out, so for bicuspid cases, I will predilate every case. In tricuspid cases, I will predilate heavily calcified valves, so that's probably 20-25%.
Is your rate of predilation higher or lower in larger annuli?
Good question. So with the previous 31 millimeter CoreValve Classic, it was recommended to predilate all cases to try and stop the device sliding towards the ventricle. For me, with the 34, it doesn't change my normal practice. I do not routinely predilate large annuli anymore.
So, message to the audience is no change in practice between small and large annuli when you use this kind of technology.
Yes.
Another technical question is, do you have a different wire for large annuli or for horizontal aorta?
Okay, so good question. I think that you need to use usually a pre-shaped wire. I think that's an advantage. And I think that the choice of the wire for me depends on how horizontal the aorta is, and we're going to hear from Mohammed about that, but also the size of the ventricle. If you have a very small ventricle, I think it's reasonable to take a small curved wire. If you have a more generous ventricle, then a more generous wire can help you. So I would rather look at the ventricle for my wire choice rather than look at the size of the valve that I'm implanting.
Another technical question. You know, guys, you have to ask questions. Otherwise, I always ask the question, it becomes boring. So if you have questions, come to the podium, ask.
I was thinking we could have this discussion afterwards. You can come and ask me if you have some, some questions.
No, you know, we have to buy time. We are too early. So, yeah, you need to know these things, guys. You know, this is like a TV show. We need to be in time. But no, it's good. It's good to exchange information. Do you rapid pace when you have large annuli or overall?
No. Again, I showed you 2 cases. In one case that we did, and that's because we had a more difficult implant. On the second case, do we routinely rapidly pace? Absolutely not.
Let's say fast pacing, I mean,
Yeah.
just to be clear.
Yeah, fast pacing, absolutely not routinely for large annuli. Do we do it when we're having a difficult deployment? Usually when the patient has moderate aortic incompetence, then I think it can help you, absolutely. If you're having difficulty finding that level, again, it can help you. But again, most of these cases, it's very stable.
Another,
I have a
sorry.
question for you. I know it's hard to discuss a little bit about off-label, but still the question comes up: large annuli, regurg, with less calcium. So in this situation with a dominant regurg, maybe combined disease,
Yeah.
in these cases you still use some pacing to follow this question?
Yeah. So we're off-label, but the vast majority of patients will have some regurgitation. And you can give patients regurgitation after doing balloon predilatation in very calcified anatomies. But so I think if during your deployment you see that your valve is changing height, therefore it's largely luck if you get it at the right height. And so if you see your device moving significantly within the aortic root, usually due to aortic regurgitation, then I think that not even rapid pacing, not pacing at 180 beats a minute, even pacing at 110, 120 may just drop that systolic blood pressure a little bit, reduce the regurgitant time, and therefore give you a more stable implant.
Okay. So, resuming, you have changed a little bit your technical way of procedure with large valves. If you remember the 31 and compared to the 34.
Yeah.
And it's a little bit more smooth and more simplified in some way.
Yeah.
It's correct?
Yeah.
Okay. Did it change something for you? The change of French size. We don't have any more 14.
Yeah.
We have a 16. It makes a difference or not?
Thus far in my practice, no. Of course, that will come into play in certain patients. Of course, you're going to have patients with smaller anatomy where you would prefer to take a 14. But this technology extends treatment to patients who could not previously have treatment. And of course, if you can't go transfemoral, then you have other access routes. But thus far in my practice, the use of the 34. I've had no patients that we've screen failed based on the femoral anatomy, because those larger patients, again, tend to have larger femoral
Yeah, so
anatomy.
since you are a smart guy, you should make a study and look at this, because I think so. I think the larger the annulus, usually the larger the vessels. It's
So
very,
large,
very
yes.
improbable that a large annulus has a problem with the access. One last technical information. Again, I would like to ask maybe the audience, how many of you have already used a 34? How many of you? So still a minority. So Medtronic, you have to improve your market
have to sell
penetration
34.
and give more devices available everywhere, because it's a good device. So we know that there is as you go up with the size, there is a little bit more of flow obstruction when you deliver the valve. Sometimes you have to you have to deliver a little bit more beyond the sound, the cracking sound. Is it the same behavior, worse behavior? What have you seen with 34?
So again, because you have a larger anatomy, you get less obstruction to flow. But then you open a larger valve in that larger anatomy, and you do get some obstruction to flow. So in my experience, I get the same period of hypotension, if you like, with the 34 as I do with the 29 and 26. Do you need to take the valve beyond the rumble strip to the point of no recapture? Yeah, I think that's best practice, that you take, you deploy until the point of no recapture, because at that point you have options. You can continue to deploy, or you can recapture. If you stop halfway towards that point, then I think you risk having a valve that is partially open. But I think if you follow the instructions and the guidance from your proctors, if you continue your normal technique that you use with the 26, 29, 23, you're going to be good.
So I have no more questions, so I'm stuck. I have a question for you. We go back one question about bicuspid. You both can answer to this, because in my own practice today, I have only one category of patients where I am a little bit unhappy with TAVI overall, which is bicuspid valves in patients with dilated ascending aorta. In this subpopulation, I've seen in my own practice 3 aortic dissections. So we know there is a aortopathy in bicuspid valves. Do you have any hard point for a contraindication in your practice? Let's say beyond certain level, you would never do TAVI, or you just... and in case you have an aortic dilatation, what are your safety features?
There are two ways to answer it. One is, do we really need a second apposition, a second anchoring, that the distal part is touching both sides? The answer is no. It's not needed. So a larger than the distal, the proximal part is not a contraindication. But I think in terms of TAVI versus a different strategy, it makes a huge sense. And that's when I see that some people saying that the bicuspid in different areas is so different in terms of incidence, maybe not due to Mother Nature, maybe due that the surgeons do not operate them like here in the 40, 50 years, and we do see different patients in a end stage. So may we have, see now patients different in special areas where we have a bicuspid with a huge anatomy and an extreme high risk, and then we are facing the challenge what to do. But if you have a patient which is doable for surgery and you have an anatomy larger than 55 ascending, I always will go for a surgical repair.
I think that's a key point. I think if you have a bicuspid patient who has aortopathy, that patient should go to surgery. If, on the other hand, the patient is not a surgical candidate, then you need to do TAVI in the safest way that you possibly can. And I think trying to avoid trauma to the arch as you come around is very important. And there are certain things that you can do to try and, I think, alleviate that. You can use a stiff wire. You can sometimes put a snare over the end of the device to literally pull it as it comes around the arch. You can sometimes use a balloon so that when you come around the arch, you inflate the balloon to deflect yourself away from the aneurysm. I think there are different things that you can try, but I think you need to be very careful coming around the arch.
Body balloon is old school. We have been doing this at the beginning. Yeah, I think it's very important again to share this experience with the audience. And I have to say another thing. You know, it should not happen. But in case you have aortic dissection, please release the valve. You may save the aortic dissection. This is a very important, unique feature of Evolut, that if you have an aortic dissection, it can happen in these patients. The aorta can dissect, and usually you are there. You know, you have this, you make your angiogram, and you see the dissection, and before calling the surgeon, I mean, call the surgeon because maybe you need it, but before calling the surgeon, just release it. Release the valve, and maybe in 50% of cases, it will solve the iatrogenic dissection. So I think it's very important.
I hope you're not still calling a surgeon, Francesco.
You know, honestly, nice. when that happens, you know, I start thinking about my agenda. So what the fuck?
I was thinking the same. Okay.
All right, good. So,
thank
you very much. I apologize, we torture you a bit longer because we had a lot of overtime. So now it's my pleasure to call Nico on podium to talk about LVOT. Do we care about the LVOT? We always do this kind of things. Do we really care about the LVOT? Show us.
Okay, so this is going to be a case about a complex LVOT with respect to calcification in the left ventricular outflow tract, and maybe how that can affect patient selection or even the decision to make the procedure. Also, when we discuss this case, let's try to keep in mind the patient's age and how this case may change if the patient were to be younger and we were treating perhaps a low to intermediate risk patient. and maybe some different procedural techniques we can use to treat these patients. So this is an 81-year-old with severe aortic stenosis, a preserved left LV function, had a previous MI, some mild kidney dysfunction, a previous stroke, and osteoarthritis of the knee. Let's go directly to the significant calcification. What you see on the right-hand side is what we call a maximal intensity projection, or a MIP. This provides you sort of a 3D representation and stacks all the CT slices on top of each other, so it gives you an idea of what type of calcification you're dealing with. You see here that you have severe calcification that extends from the leaflets down onto the anterior side of the mitral valve leaflet, and there's also some mitral annular calcification. And you see here now we're in the shorter axis view of the valve. Now, let's talk about calcium quantification. Very important. When you have large annuli, you will measure much more calcium because it's just a large anatomy. When you have smaller anatomy, you're going to measure less calcium. So very difficult to understand what is high and low calcium when it comes to quantifying calcium with respect to millimeter cubed or volume of calcium. What we're doing here is trying to understand the volume of calcium, and what we're doing is we're using a calcium threshold. So if we go back here and we play this, what you'll notice is that the middle screen is going to become completely red. That is because we're decreasing the threshold, and the computer program believes that everything is calcium. Of course, that's not the case here. So here we put the calcium threshold at minus 1,000. Now, if we increase that threshold to plus 1,000, well, not much is greater than 1,000 Hounsfield units, so we're not getting all the calcium. So we have to titrate our calcium threshold and find the right Hounsfield unit for this particular patient. And you see here we can have a little bit of noise, and we reduce that noise, but this gives us an idea of how much calcium we actually have in the region of interest. And here we're going to measure approximately 2,960 millimeter cubed of calcium. Just in general, if you have less than 500 millimeter cubed of calcium, it's considered mild. 500 to 1,000 is average from what we see over hundreds of patients. 1,000 to 1,500 is severe, and once you get above 1,500, it's considered extreme. So this is just another representation of using the MIP now plus the region of interest, and again, just to give you an idea of what type of calcium we're dealing with. When you look at the CT measurements of this particular patient, the perimeter was 83 with a diameter of 29 by 22. The sinuses of Valsalva were generous at 31, 30, and 32. Very important when you're dealing with very calcified valves, because you want to make sure that you're not going to occlude the coronaries. And you can see here that the coronaries arise at above the aortic valve leaflet. So just scroll up and down across your sinus of Valsalva, see where those aortic valve leaflets finish. And if they do finish before the takeoffs of the coronary arteries, even in the presence of even maybe perhaps small sinus of Valsalva or extreme calcification, you might mitigate the risks of coronary obstruction. So let's go to the case. We selected a 34 millimeter Evolut R in this case, based on a perimeter of 83, so we had quite significant oversizing. We used the double S curve in order to get proper positioning. And what you see on the right-hand side is some significant paravalvular leak, as probably you'd expect given the challenging anatomy. So what do we do next? The height needs to be confirmed. So on angiography, it looks as if we're implanted about 3 to 4 millimeters below the annulus, which is acceptable. It wasn't too low. And on echocardiography as well, we can see that the edge of the inflow of the core valve is nicely seen, and we're at an appropriate height. So we've confirmed that the height is not a problem, and that we're perhaps getting all of our radial force from the inflow portion of the valve in the appropriate area for sealing and anchoring. Once we do that, the next step is to do some color flow Doppler, and it was actually very difficult to appreciate the aortic regurgitation on echo in this patient, and for some reason it looked worse on the angiography than on the echocardiogram. Of course, we see that at times. But nonetheless, we proceeded to post-dilate with a 25 millimeter balloon, and This is the largest balloon we would choose for a 34 millimeter valve. So we performed that under rapid pacing, of course, in order not to dislocate the valve, if you would not happen to do that. And so we did a reassessment of the aortic regurgitation, and it improved on angiography. But still, there was, you can see on the echocardiogram, there was, let's say, a valve or a frame malapposition, and you can see that the leak was actually coming from the side where the calcium was the worst. It was coming from the anterior mitral valve leaflet side. And so we went ahead with a second post-dilatation with a 25 millimeter balloon, this time a little bit more aggressive. We gave a little bit more volume in the balloon. And you see that we got some expansion of the frame and some retraction. And so this was the final angiogram, and you see that the aortic regurg clears with every beat. And on the also on the echocardiogram in the short axis, there was a significant reduction in the aortic regurgitation. So just some thoughts about sealing when you speak to engineers and when you think about how valves seal. There are three major things to think about. One is conformability, so you want a valve that's going to conform to the anatomy. That can happen along not only with the nitinol frame, but also if you have a particular skirt. Second, you want to optimize the sizing, so you need the right oversizing in order to seal, and that might be different from valve design. And third, you need a valve with sufficient radial force. These are the three major criteria. There may be some other little ones, but these are the three major criteria that we think about when designing a valve for sealing. And just to give you an idea that, we do see some mild paravalvular leak after these procedures, as was in the case, but sometimes we definitely see an improvement over time, and I think this just paints the picture beautifully. You have a nice biological seal that happens, and you can imagine that if you have this ingrowth at the inflow portion of the valve, that basically you do not get any more regurgitation over time because of just the biological sealing, as we call it. So this is, these are explants at 1 and 2 years, respectively, on the left and right-hand side. So in terms of discussion points, we can keep this slide up for discussion. First is, how do we qualify and quantify the amount of calcium? There are quite a significant number of limitations in actually quantifying calcium using CT scan. In one particular patient, I remember we had a patient who had a contrast CT and a non-contrast CT. And we measured the amount of calcium in both scenarios for one particular patient. And in the non-contrast CT, it was, just 2,000 or 3,000 millimeter cubed. With a contrast CT, it was much lower. And again, this has to do with the fact that what you're trying to do is sort of find the difference between the background and the calcium. And it's all about Hounsfield thresholds. So that's one question we can discuss. The second one is, are there any additional technical difficulties that you might encounter when you have patients with LVOT calcification that might make the procedure difficult, for instance, a horizontal aorta that we're going to hear afterwards. I think a very important question as we're evolving with TAVR is, what do we do with low to intermediate risk patients with severe calcification? Are we going to get to a point where we're going to understand the limitations of our therapy and perhaps provide our patients with the best possible care? Third, when we deal with these type of anatomies, what type of TAVR platform do we want? Do we want a self-expanding one, or do we want a balloon expanding valve, or some other type of expanding valve? Lastly, perhaps we can think about some best practice guidelines to treat patients with severe LVOT calcification. Thank you very much.
So, Nico, keep the slide on so we can
Okay.
use it. Thank you. So we don't forget all your questions. You can also start giving us the answers if you want. First thing I want to share with the audience a very important technique you need to learn from Nico Piazza when he is presenting. You are a good presenter, but there are tricks you need to learn. He gained 30 seconds more just clicking on the first slide after he made the introduction. So if you want to speak a bit longer, don't click on the slides, okay?
Never
did
thought
I
about
catch
that.
you?
No, that's good. That's a good point.
He's observing you with very care.
That's okay. I didn't think about that, but I'll use that next time.
It's good. It's good.
That's very good.
And secondly, I think this topic is very important. I was teasing you. I think really we don't look at the LVOT enough. I think it's one of the key issues for selecting patients. So now we have already one question. You have to go on the mic, and so that we can record what you ask.
It's well known that calcification in the LVOT is a risk for annular rupture for balloon expandable valves. And another risk is repeat postulations in self-expandable valves. You did 2 postulations in this case, and what is your recommendation? How many postulations can we do in this type of valves? Thank you.
Sure. I think your first concern is correct. If you have this type of calcification, and it's been published and shown that if you have LVOT calcification, you're at risk of annular rupture. And usually this annular rupture is because you have differences in compliances within the tissue. So you have severe calcification and then a junction that goes into healthy tissue, and that sort of area is very prone to rupture. So yes, you got to be careful using balloons in these types of patients.
Nico, before you go to the
yes.
second, let's.
I'm not finished the first.
Okay. Man, don't go. I thought you was going to the second.
No, not yet.
Right.
And so we tend to not predilate in these patients. So we try to stay away from predilatation. And I was going to go to my second question, but I'll wait.
Yeah,
now.
well, wait a second, because I think it's an important question.
Yes.
So first of all, I would like to ask you, is the location of the calcium predicting rupture? I mean, it depends on where it is the calcium. Having calcium in the LVOT doesn't mean that there's a risk of rupture. It is location also important.
I don't know about that, Francesco, but when you have these calcifications that extend into the LVOT, they typically extend in a sort of aortomitral fashion, where they extend across the anterior mitral valve leaflet and then blend into a MAC. Of course, you can have calcifications in different places, but this is the typical calcification pattern.
Yeah,
the other type
there
of
has been studies on this.
Sure.
First of all, let's clarify. LVOT is made half it is
Muscular.
muscle. The other half is a leaflet, so is anterior leaflet. So there is no annular rupture if you go if the calcification is the mitral leaflet. I mean, a calcification in the anterior mitral leaflet is a risk factor for PV leak, but not for annular rupture. Whenever you are on the muscular side, you can have ventricular ruptures, particularly if you are on the left side, if you are in the left trigon, and you can have VSDs if you are on the right side of the muscle. I mean, this is just thinking about how the LVOT anatomy is, you can understand. If you have a rupture on the left side, that is basically you are confining with the outside of the heart. If you are on the right side, you are within the muscular septum, so you get VSDs.
I would add also the diameter. I mean, if you have a calcium according to the small diameter, then you have more chance of rupture than if you have it on the long diameter.
Nico, I think your case presents very nicely the problems we are facing nearly every day. First, the difference between angio and echo. So you have to use all modalities to be sure what is your final result in terms of decision making, what's next. That's first. Second, you use the balloon, and I really like to use the same balloon 2 times, because very often you do see that they are going very quick, balloon up, balloon down, because they want to keep the period of rapid pacing short. That means they don't use the balloon properly. And if you do a second balloon, maybe volume controlled outside to see which volume is needed, then you use the same balloon and you have an effect, also shown in your case. That is very nicely shown. I want to make it very clear. So the message is, if you choose a 25 balloon and you see no effect, use the same balloon again and clarify that you do a good controlled inflation.
Yeah, and that responds to your second question.
Thank you. But just one comment. You have used the nucleus balloon. Some comment on the balloon. That was a nucleus, right?
Yeah. We typically use nucleus balloons. That's what we have on our shelves.
Do you prefer them in the post?
We have also Mullins balloons and Taishaks, yeah, but we use nucleus balloons.
But you use them because it's a post-dilatation?
We use them both in pre and post, and what I like about the nucleus in some ways is that at the inflow you can get maybe a little bit more expansion. Yeah.
Yeah, we also use the V8 balloon, which is a little bit different from the nucleus. The nucleus at the end expands all the way.
Yeah.
The V8 remains constricted in the middle, and so you can probably exert more force on the inflow to get more. Let me ask you one more question about sizing of the balloon. So post dilatation, you say you use a 25 maximum for 34. How do you really choose the balloon size? I mean, there is any other
Sure,
rule?
yes. You know, sometimes you can look at the CT scan and look at the, it was alluded to by Sonia, sometimes looking at the minimum diameter. And that might help you understand whether or not, if your minimum diameter is 18, you're not going to, it's unlikely you'll take a 34 valve. But nonetheless, I think you got to incorporate those CT measurements before in balloon sizing. But here we had a very large sinus of Valsalva. We had a large anatomy. We were comfortable with taking the largest balloon.
So let me make a question to everybody. So everybody, I think, does it different. So it's good to know. So the way I do it, I tend to use a small balloon to start with, because sometimes you don't need full expansion of the balloon to win this resistance. So you should probably start with smaller sizes. And I never go with a balloon which is larger than the perimeter or the diameter of the annulus, whatever it is. So this is my rule. I was making a lot of mistakes in the past. 29 valve, 28 balloon. Okay, this was the kind of thinking. Today, my rule is very simple. I measure the annulus. The derived perimeter is my maximum balloon.
I would add, sometimes I go in another projection with fluoro before doing the post-BAV, and I look exactly the expansion.
So
of the
actually,
valve.
that's a good point, Sonia. It's a very important point. The typical minor axis of the aortic valve in about 95 to 99% of patients is seen in an ariocaudal view. And so if you do a post-dilatation or even a pre-dilatation, that is correct. We tend to like to do that in an ariocaudal view, which is in the minimum diameter of the aortic valve. So ariocaudal.
Your practice?
I do the same. So I'm looking for the elliptical shape of the inflow frame. And if you remember my case, what the balloon did, one dimension was unchanged and one dimension was improved. And that is exactly what we need. We have to look for the smaller dimension, need some better apposition, and we not have to have a full expansion of the whole frame. That is basically the background from your strategy.
And yours?
So I would reiterate everything that's been said, but I think that you should go into your case having looked at your CT scan and know what is the largest balloon that you're going to take. I think you should be armed with that piece of information in case you need to post-dilate, and you should know that going into the procedure. For me, I take the large diameter of the LVOT, I take the minor diameter of the LVOT, and I take the mean. I also do the same thing for the sinutubular junction, because sometimes you can have a very small sinutubular junction. And I think the message that you're hearing from all of us is respect the anatomy. If you stretch the anatomy, you're going to have problems. One final point, I have a 28 millimeter balloon on my shelf, and in my 34 millimeter Evolut R experience, I've used it 3 or 4 times. Again, if you have a very large LVOT and anatomy, I think it's very safe, but you should probably start smaller and work your way up.
Right. One other question, please.
Can I get back to the characterization of LVOT calcium? You
Sure.
talked about the importance of quantifying it, but let me ask you again about how to qualify it. I mean, not only where it is, but I mean the number of calcified spots in the LVOT, the distance between
Sure.
them, the extension.
Yes.
Does this impact your decision which
Very
valve
much.
you take and where to implant it?
Yeah, that's a very important point. One thing that we tend to look for also is the pattern of calcification, like you point out. Probably the most scariest pattern is when you have 2 pieces of calcium right next to each other, separated by a distance of about 5 or 6 millimeters. Because what happens is that now you have these 2 boulders of calcium, and your frame sort of creates a bridge across these 2 pieces of calcium, and now you have a gap. We've experienced that 2 times in the last year. And I think that just alludes to our, maybe becoming a little bit more aggressive with TAVR. But in one of those cases, it led to just a single large hole leak, and we had to close it with a plug. So again, if you have two pieces of calcium side by side in the LVOT, especially if they're in the vicinity of a commissure, that can lead to creating a bridge with your frame and a gap and creating paravalvular leaks.
So, Nico, I think I would like to make a last assumption. I want to know your opinion. I think I'm a strong believer of these technologies, and I'm one of the few surgeons who have been always pushing for low and intermediate risk patients. On the other hand, the number one reason for me in my practice to turn down patients intermediate risk or low risk is LVOT calcification. So I think really this is a very important topic, because LVOT calcification is predicting for PV leak, for AV block, and for annular ruptures. So I think really, if this happens, don't push the limits. I mean, surgery is not fine, it's not nice. Nobody wants to be operated. I don't want to be operated. But these patients probably would benefit from surgery if they are low risk. So have a look at that. And again, you have to have a look at that. Don't let the guys from radiology give you some slices that you don't see the whole thing. You have to really look, make like you have shown, analysis of the all components, starting from the LVOT going the ascending.
And just to take off from that, Francesco, we typically say, at least for low to maybe not now intermediate risk patients, that TAVR is reserved for patients who have a contraindication to surgical aortic valve replacement. I think when we move forward and start to get more data in low and intermediate risk patients, and now we're seeing it intermediate, of course, we're probably going to be hearing that surgery is going to be reserved for those with a contraindication to TAVR. And that contraindication to TAVR is not going to matter whether you're low, intermediate, or high risk, but we're going to be looking at anatomical criteria, I think, more in a more strict sense, and to try to learn exactly where is the line where we get optimal results with TAVR versus SAVR.
So is it the end of the concept of ad hoc TAVI?
Not necessarily.
Why not? I mean, if you go in this direction, really, you need to CT scan every patient.
Probably, yes.
I think mean, if you believe in this.
No, but look, I think we can't leave this room thinking that we're going to be doing ad hoc TAVIs. I think we have to select our patients very carefully. We have to image them very carefully. So, yes, there's still a role for patient selection, as opposed to doing an ad hoc TAVI in your cath lab.
Okay. Thank you, Nico.
Thank you.
I put you in the corner.
So now we are hearing another complex situation, which is horizontal aorta, from Mohammed Abed Wahabi.
So I'll try to make use of the trick you just suggested, Francesco.
That's not fair.
Okay, so thank you for having me here, and I'll be talking in the next few minutes about Evolut R and horizontal aorta. So there are definitely challenges all of you are aware with when we're treating horizontal aorta. The first thing is to try to define what a horizontal aorta is, and I think there are no clear cutoffs in the literature, but I mean, if you look at both images here, you can clearly differentiate the one with the horizontal aorta as compared to the one with the vertical aorta, and there are definitely some considerations when you're treating these patients. First of all, regarding sizing, it seems to be more common in males with large anatomies, and we've seen that these are particular situations where you have to be aware what type and what size of device you're using. But there are also problems with valve crossing regarding wires, balloons, and the prosthesis. And what I have here in bold are the 2 points which I think are very essential. One is valve alignment, and the other one is having the control during the whole implantation procedure. There are some published studies about the impact of angulation on outcome. So on the left-hand side, you can see a study of our group, which is rather old now, published 2010, where we've noticed that there is an impact on the angle between the aorta and LVOT on the occurrence of more than mild AR after implantation of CoreValve Classic. There is one paper from the group of Raj Makkar, which have measured the angle on CT and have seen that there is somehow a cutoff value which influences the implantation success with CoreValve but not with Sapien. But on the other hand, you can see on the far right a very recent analysis from the US CoreValve experience where angulation did not impact the procedure success with CoreValve. So there are no data about Evolut R, but definitely there are some advantages of this prosthesis. First of all, we have, of course, the larger size, which improves sealing in large horizontal anatomies. I think one of the advantages is the less stiff catheter, at least in one plane, which facilitates tracking on the outer curve of the aortic arch and eccentric crossing of the valve, which is very important, and I'll show you in a couple of examples. The self-centering property helps positioning the valve, and very important, in my opinion, the recapturability, because it gives you real control during implantation because of the angulation. There are, though, remaining challenges, and this is why you have to be cautious when you're treating this type of an anatomy. So the catheter is not steerable yet, so alignment may be difficult, and it definitely depends on the type, shape, and stiffness of the wire you're using. Self-centering could be more difficult in horizontal anatomies. The position needs definitely assessment in different views. So even if you're very experienced and you think you're right, I would encourage you to have a look at different views and particularly pay attention to valve stability during release because it may be suboptimal. So I'll show you 3 cases. I'll start with what I call an ideal case. You can see here on the left-hand side the usual 3-cusp view, and you appreciate the horizontal angulated aorta. And you see on the right-hand side here a good wire shape and position. This is a safari wire with a small curve. And what I mean with a good wire shape and position is that the wire adequately fills the apex, and the wire is eccentric and well aligned. So eccentricity here is, in my opinion, very important. This is what we call in PCI wire bias, but it helps you really to align the valve with the horizontality of the anatomy. And can you see here, if you pay attention to the wire from the beginning, choose the right wire and place it correctly, you will not have big problems in aligning the device in this horizontal anatomy. The rest of the procedure would be rather straightforward, so slow release as you're used to, plus minus fast pacing if you're not sure that you're maintaining a good position or a stable position during implantation, but this is not a must. And when you reach the point of no return, as mentioned by Darren a few minutes ago, you have to, in my opinion, stop, assess. You may need to change the view and make sure that you have the adequate depth. And when you release, it's very important in these types of anatomies really to follow the guidelines we all know. Release the tension, slightly push on the catheter, and most importantly also very carefully retract the nose cone to avoid any interaction with the stent frame, which may lead to malposition after final release. In this case, the result, as you can see here, is very nice with almost no aortic regurgitation. And this is really like a case which went nicely and fine. A suboptimal case, on the other hand, again, horizontal aorta, a 3-cusp view, and you can see here on the right-hand side what I call a bad wire shape and position. This is a safari with an extra small curve, which I stopped using in horizontal anatomies completely. So the size of the curve is, in my opinion, also a very important aspect because it will allow you to fill the apex and maintain eccentricity, which was not the case in this scenario. The wire is not well seated in the cavity. The wire is very central, malaligned, and you can see here that the prosthesis is coming in a very bad angle, which will make the rest of your job very difficult. So you can see here that it was decided to implant the valve, and as you might expect, you will have the valve higher on one side, on the non-coronary side usually, and deeper on the other side. This is difficult to correct. You can try to correct it before having complete annular contact by slightly pushing on the catheter, which will get it a little bit deeper from the non-coronary side and higher up from the left coronary side. In particular, you may want to change views and make sure that you're still anchoring on the non-coronary side. In this particular case, even after doing these maneuvers, the valve was implanted deep. It was fortunately after post-dilatation, it was sealing, but this is not the optimal scenario and you can do it better. The last case I'm showing you is what I called the beware case. Again, a very horizontal aorta, very good wire shape and position, similar to the first case. This is, again, was a safari with a small curve. Very important that the wire fills the ventricular cavity, well seated in the apex. Again, wire eccentricity and alignment. You can see here the unsheathing of a 34 millimeter Evolut R being placed at the recommended position. But what may happen, particularly in horizontal anatomy, the forces here are a little bit different, that you can get dislocated. This is a cranial dislocation, but no problem. The valve is recapturable. You can simply recapture in the ascending aorta and recross. One of the very important advantages of this technology. Here you have a slightly deeper position to start with. The valve was unsheathed in this case a little bit more rapidly to allow rapid annular contact and prevent malposition. And then we changed angiographic views and waited a couple of minutes to be sure that the valve remained in a stable position. And while releasing the valve, you can see here that the forces will not release perfectly. So the valve popped up a little bit, around 2 millimeters from the non-coronary side. But as we were aware that this could happen, we were particularly deeper on that side. And this allowed us to achieve the final position, which is actually perfectly well with good sealing. So be aware of these minor tips and tricks. We know that angulated aorta and unfolding requires additional planning before and after the procedure. It should be measured, both. It can be measured both by angiography and multi-slice CT as you've seen, but it also should be judged in the context of the annular size and the amount and distribution of calcification. I think that the Evolut R has important advantages compared to the CoreValve Classic, which facilitates implantation in these particularly challenging anatomy, particularly recapturability. But wire selection and positioning remain essential as long as the catheter is not steerable to optimize your implantation. And you have to maintain and keep careful attention to really each procedural step in order to achieve adequate results. And thank you for your attention.
So thank you very much. I think you pointed out several times unfortunately the device is not steerable. Would you like to have a steerable one?
I would like to have a steerable one, yes.
So listen to the guys, you know, we all like to have a steerable one. So I think one comment, or let's say one feature that you didn't cover is if you have a very horizontal aorta, one alternative could be, I don't do it anymore, I've done it in the past when I was a little bit less experienced, but one alternative is alternative access from the subclavian artery where you have more control. So for those who have a little bit of problems with the horizontal aorta, keep in mind that this could be an alternative which works well, very well for horizontal aorta.
I think this is correct, particularly from the left side, of course.
Yes.
Don't
go right.
Yes, don't go right. I don't know if a direct aortic access would also facilitate horizontal aorta. I don't have experience with
obviously, that. Yes. It is obviously an excellent alternative. Horizontal aorta also will qualify for minimally invasive approach because usually the right thoracotomy gives you a nice access to the aorta. So there are alternative access. Just to mention, I think in my opinion, as you get more familiar with these procedures, honestly, I don't need that anymore. I learned how to play with wires and I know more about how the device behaves. So, but keep it in mind.
I have one comment. So if you look about the definition of horizontal aorta, you do know that we get the implant view from the angulation from the CT. I warn you, you may be fooled. If you get a 76-degree
implant view, it may be truly 90 degrees horizontal. Don't count on the CT alone saying horizontal or no horizontal. Be aware it might be a horizontal. That is first.
This is very correct. So I've seen this also in my practice, and fortunately we're still doing the old-fashioned aortograms when we do coronary angiogram, and this helps you a lot to get a feeling for the anatomy before you get involved.
Just add a little bit provocative. In your third case, you have this change in the final release. Maybe you can relax the wire a little bit more, that your wire is not giving you some forward tension. Just to be very, clinical.
I think he mentioned they did not release.
This is exactly correct. So this is why you have to pay attention in these complex anatomies really to each step. So if you don't do this with the straightforward anatomies, probably they will forgive. But in these anatomies, you have to really be very attentive to these small details.
Nico.
Yes, on. So, one thing that we always tell, whenever we're proctoring or teaching our fellows to do these complicated cases, we always tell them that the first operator and second operator can only push things. That's it. They either push the wire or they push the catheter. So if your valve is too low, the second operator is going to push the wire in order to lift up the valve. And if the valve is too high, the first operator is going to push the catheter in order to bring it down lower. Both of those are always going to keep the valve against the outer curvature and keep it coaxial, but always have the first and second operator push things, never pull during those types of procedures.
This is extremely important and also underscores the importance of the coordination between the first and the second operator in these complex anatomies. Because simply if you're pulling on the device, you're losing this eccentricity which you like to have.
If the first operator pulls, he's going to bring it closer to the inner curvature, and so will the second operator.
Obviously, again, a little bit word of caution here. Wire perforation may happen in these patients. This is a subgroup of patients where this may happen more often. There are two complications that I've seen in these patients beyond the malpositioning is wire perforation of the apex because you're pushing. We have to push to be aligned. The second one has been aortic dissection. When you have shown one reposition, one recapture and reposition, be sure that you recapture correctly, because crossing the valve in a very horizontal aorta may be more complicated. You have much more friction. So if you don't have re-encapsulation, total re-encapsulation of the valve, go in the descending aorta, do the full recapturing and come back. Take your time. These procedures are difficult.
One other thing that can help you in these cases is if you pay attention to the ring. If the ring of the device is horizontal, like this, then the catheter will not bend in a lateral fashion. If, however, the hat ring is on its side, so you look at it like this, then you can push a little bit on the catheter and the capsule will bend in a lateral fashion. So paying attention, I think, to the hat ring of the device can also allow you to get a little bit more on that outer curvature, and may also allow the device to open up in a different plane. So sometimes taking the device back into the aorta, torquing the device can help you.
And I would like to also mention that horizontal aorta is probably a simplification of the concept. The concept is what all this information are very important whenever your angle of approaching the annulus is not coaxial. I mean, this can happen also in the vertical aortas. At the end of the day, the problem is the angle between the ascending aorta and the ventricle. Nico, maybe you have done some work on this with your app.
Whenever you look at vertical annuli in the body, again, as Darren was demonstrating, if you imagine that vertical annulus in your body, okay, it's going to look like this. So this would be a horizontal.
Maybe you come in the middle, because so we can take you.
This is a horizontal annulus, and this is a vertical annulus. So you can imagine that if your C-arm has to look at this annulus in plane, it will have to go cranial caudal, and it will always see it in plane. Okay? So your S-curve, if you plot out all those points of where your annulus is in plane, it's going to be a vertical S-curve. Okay? Why is that important? Is because if you understand in what plane that annulus, in what RAO or LEO projection that annulus is in plane, then what you need to do only in the cath lab is, suppose it's RAO 20, go into RAO 20 and just go cranial or caudal until your delivery catheter is in plane, and then you'll have both your annulus and your delivery catheter in plane. Does that make sense? So I'll repeat it. So you have...
No, I think it's clear. It's clear.
Yeah.
It's clear. We understood.
Yeah? Yeah,
So I think it's time
It's
to
good?
close up. Yeah, it's
Okay.
clear. It was very clear. I understand. Cranial, caudal, everything. S-curve, everything.
All right. Very good.
No, not kidding. Really, it was clear. I think it's time for to close the session with Sonia, who will tell us. Sonia, what did you learn? Did you learn? Did you learn something?
Well, I know I have to say that I would like to thank the... Okay, I didn't... Can you explain it back to me, please? Okay, so anyway, I have to thank all the speakers because they were really complex cases. And, I asked myself why we were talking about this today is that if TAVI is expanding the boundaries, then we need to optimize our procedures. And, trials are getting with the risk score always lower, but in the true, the TAVI centers are already doing intermediate risk and sometimes lowest risk patients. So we have to pay very attention, and the younger patient we will treat in the future, we will probably see more bicuspid valves, and these need to be pay a little bit more attention, a little bit more of study. We have to recognize bicuspid valves, we have heard. We've got to optimize the sizing, knowing and looking ourselves, CTs, images. We have to consider not only undersizing, but what to look in the annulus, and not only in the annulus, but in the mouth of the valve, which is the raphe and the calcification distribution. And with a good result, we can be achieved with a supraannular valve, which has been showed from Ulrich. A large annulus and horizontal aorta, these are challenging situations that are getting more simplified by the new techniques and new generations valve. That now that are retrievable and repositionable, if you begin to plan and know exactly what you are going to do in the procedure with the planes of the flora, as we've been hearing just now, you can achieve a good result. Repositioning and recapturing, I would add, are something a tool that you have in your hands, but the best thing is to begin from the first moment to plan a good implantation, because retrieving all time a valve can be not a good thing to do. You've got this option in your hand, hold it, but not do it all the times. Last was a very interesting observation done by Nico on the problems of LVOT, and especially on distribution calcification in the LVOT. We are getting more skilled, and we have done more TAVI nows, and we are able to plan what will be the result of our procedure. But again, now that we are facing to intermediate risk patient, perhaps sometime we should stop, we should look carefully what we are going to do, and sometimes call the surgeon again. Thank you.
So with this, I would like to thank everybody for your attention. Unless you have any really boring question, we say ciao ciao. But if you want to ask questions to us, if you didn't understand this thing from, Nico is still there.